Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Great. Thanks so much. It's always fun to be here. I am going to talk about ID Week this year, which was last week. And I'll focus a little bit more in, because it's an enormous conference, and talk about HIV highlights. And they'll specifically be my highlights, so they're biased in that way. I have no disclosures, any trade or brand names. I'm just using for identification purposes. So today I wanted to highlight kind of three sectors. And so the first two will be their own oral abstracts, and then a couple related to HIV primary care screening. But the first will be about lenacapavir, the second will be about zoster vaccination, and then the third we'll talk about osteoporosis screening and colorectal cancer screening in people with HIV. So we'll start off with lenacapavir, because I think that is always exciting to talk about. So I know in this forum and many others, we've talked a lot about lenacapavir. And so, as just a recollection for all of us, it's a first-in-class HIV capsid inhibitor. It's been approved in treatment as salvage therapy for HIV in combination with an optimized background regimen, usually oral therapy, although we now use injectables as well. Most of our data, though, is from the clinical trial world, right? And so the Capella studies, I think, have probably been covered here. There's minimal real-world data, although concurrently, I should say, in this session, there was also a presentation about another real-world cohort. I just found this one a little bit more real, if that makes sense. And so the question that the authors of this study asked are, what are the real-world outcomes among people with HIV who start lenacapavir for salvage therapy? And so again, the study was called Virologic Outcomes with Lenacapavir in Heavily Treatment-Experienced People with HIV, a multi-center real-world study. And so what does this mean? They looked at retrospective data in this cohort in those who initiated lenacapavir for salvage therapy from November 2020 to June 2025. And who were these people? So I'll say that these clinics were mostly in Chicago. I think there were 4 Chicago clinics and then 1 affiliated with the University of Pittsburgh. The authors collected demographic and clinical characteristics, including their antiretroviral therapy, so both their prior regimen and what they were getting as an optimized background regimen, or OBR. They had data on genotypes, and I'll also say that they collected archive, so DNA genotypes on people who had those, and then obviously they collected viral load and CD4 counts. And they performed survival analysis for time to viral load suppression, and also, I think really interestingly, compared the number of active agents, total agents, and pill burden pre and post initiation of lenacapavir. So from this study, 70 patients met criteria. There were 54% male, 73% Black, something like 90% non-Hispanic, 73%, interestingly, were on Medicaid or Medicare. The average age at lenacapavir initiation was 53 years old, and the average duration since diagnosis, or time since diagnosis, was 24 years. At initiation, 54%, so about half of the cohort, was virally unsuppressed, and of those 4 had a viral load of greater than 100,000 copies. And what you can see in the table here that I took from the presentation is the distribution of resistance. So you can see that the majority of the patients had, unsurprisingly, NRTI and NNRTI resistance, so 79 and 74%, but there was also a good mix of PI and INSTI resistance, and 7% with resistance to all 4 main classes. And then you can also see the estimated number of active agents pre-lenacapavir initiation. I think a pretty good distribution. At least, I will say that 2/3 had at least 2 active agents, so that is something to think about. And then what were the results that they found? So in terms of the medications and the optimized background regimen, perhaps unsurprisingly, the most common medication class were the integrase inhibitors, but you can also see that there were a nice distribution of other classes. 89% of the individuals who were initiated on lenacapavir in the study time period remained on lenacapavir by the end. 82% of those who were initially viremic, so remember that was about half of the population, became suppressed, and all those who were initially suppressed did remain so. And then the other thing I wanted to highlight is that I know we talk a lot about injection site reactions with lenacapavir, and this kind of held true in this real-world data where about 1/3 of the population did have some sort of injection site reaction at some point. All right, so now let's look at the virologic outcomes. I know that first figure is really funny because there's just so many squiggly lines, but these are the people who were viremic and then what happened over time. And you can see that overall there's quite a lot of suppression, although I think what's interesting is there's some bouncing around in there. That dotted line is the 200 threshold, so what we would consider undetectable. You can see that there's that prominent line up at the top and then that pink line that creeps up of two individuals who clearly did not suppress and remained, and one who really just remained viremic. And when in the Q&A, somebody appropriately asked about those two patients, it really seemed like those were people who discontinued their optimized background regimen after initiation of lenacapavir. I think, and this was interesting to me. One, I think, didn't quite understand that they were supposed to take it, and the other just, I think, loved getting an injection, was like, I just don't want to keep taking pills anymore. So I don't think it was just education, just as an aside. And then you can see the time to viral load suppression of the 36 viremic people. Again, 80% get suppressed, and you can see that it looks like a really long tail for suppression, but the presenting author pointed out that viral loads weren't necessarily checked super frequently. So some people may have had a large gap before getting their next viral load checked. Again, that's not because clinicians didn't want to do that, but this is a real world study. And so people got their viral load when they got their viral load. Okay, and then what about some of these practical things that I think we think about when we're counseling our patients? So what was the change in the number of daily pills? So first I'll say for the number of daily pills, if it was a BID medication, so say someone was taking BID dolutegravir, or they were taking Maraviroc or fostemsavir, that was counted as more than one pill. So it's not just the drug. And so you can see that there was a significant decrease in pills per day, perhaps unsurprisingly, with the initiation of lenacapavir. And then I also wanted to include that even though it seemed a little low to me to say the number of ART pills prescribed per day was only like a little less than 2 for some people. Remember, this count combination therapies as well. So Simtuza would be 1 pill. And then if you look at the distribution in the chart, there were people who are on more than that. But you can see that there was a significant decrease post lenacapavir initiation. I'll also note that you see that little caveat that this does not include long-acting injectable or IV antiretroviral therapy, which would really be ibalizumab. And 19 people in their cohort ended up on either Cabenuva plus Len or some combination of things with ibalizumab as well. So that's not counted in this. What about the change in the number of medications? And again, this is the change in the number of active ingredients. So Simtuza would count it as 4 because they count the cobicistat in that as well. They cited that. So you can see that the number of prescribed ART medications didn't really change, which again is perhaps not unsurprising, but pre and post Len, we had about the same number of medications before and after. So what were the author's conclusions? Most people with HIV initiated on lenacapavir maintained or achieved new HIV viral suppression, even in a real world setting. Active agents in the antiretroviral regimens increased, but the number of daily pills decreased, and there was no decrease in the number of antiretroviral agents with lenacapavir initiation. I didn't highlight the other study that was presented in this session. That was the OPERA cohort that's had some data presented at other intervals as well. I liked this one, or I thought this one was relevant because I had so many people who were virally unsuppressed. I think in the OPERA cohort, which is mostly, at least Karim Monzer is in Philadelphia, had a lot of people who were virally suppressed already and then and then added Len. I just thought this was a really nice proof of concept in people who were half of the population was virally unsuppressed and failing their therapy before they started. So I'm going to switch gears entirely from long-acting injectables and talk about zoster vaccination in people with HIV and their cardiovascular and mortality risk, and I should mention also neurocognitive risk as well. So the background here, and so this was a study out of Case Western, or led by a group out of Case Western. So herpes zoster and HIV is very common, even for those people who are on antiretroviral therapy. And that's because HIV worsens vis-a-vis specific CD4 T cell immunity, which boils down to zoster episodes are earlier, recurrent, and more severe than in people without HIV. And that's what's led to the recommendation that we all know about now for earlier vaccination in people with HIV than people without. Also important to realize, though, is along with the rash, there's inflammation increases with zoster, and that's both vascular and neurologic. And many people with HIV may be more prone to have silent zoster, and thus inflammation without any lesions apparent. Stroke and cardiovascular risk in terms of MI may rise post-zoster. And then we also always talk about how people with HIV already have an existing inflammatory burden that may predispose them to these outcomes. And so, what about vaccination? We know that the RZV vaccine or Shingrix restores VZV specific CD4 immunity. And what the authors sought out to answer, I think the question that I thought was most relevant, although they answered two questions, is does zoster vaccination reduce those vascular and cognitive complications in HIV? So this study was called Zoster vaccination in people living with HIV is associated with reduced mortality and cardiovascular risk, a real world matched cohort study. So you can see that kind of got to the punchline there. This was a retrospective propensity score match, and I won't go into every single thing they matched for, but basically it's all the things that might contribute to poor cardiovascular or neurocognitive outcomes. So things like comorbidities, their demographics, all of the ART they've ever been on. And this is from the TriNetX research network, which derives data from more than 100 US healthcare systems. They look specifically at people with HIV over 50 years old on ART. And so I told you that they asked about vaccination, but they also asked the question of what does zoster infection per se do? So the first part of the analysis was looking at people with uncomplicated zoster infection versus people without. And they had follow-up from day 90 to basically year 4 or 5. And then they also did an analysis of the effect of vaccination by looking at people who were vaccinated with RZV versus the control of PCV. They excluded all people who received live zoster vaccination. And then I thought this was interesting, looked at 3 time windows. They looked at early, right, after vaccination, in a late period after vaccination, and then they combined all that data. Their primary endpoint was the MACE outcome, which, as a reminder, is acute MI, ischemic stroke, hemorrhagic stroke, and cardiac arrest. And they also looked at secondary endpoints of isolated MI, ischemic stroke, venous thromboembolism, all-cause dementia, and all-cause mortality. And so just to get a sense of what these groups look like, you can see that per arm post-matching, so post that propensity score matching, they're about 1,300 in the infection per arm study. And then in these vaccine early, late, and combined, they look at this cohort of 2,700 people, but then just extended their data frame to the appropriate time period. Okay, so I tried to get some punchlines out. They had a lot of Kaplan-Meier curves too, but I think I just wanted to get to these forest plots because I think they tell the better story. So cardiovascular risk was higher in people with HIV with zoster infection. And so you can see it's actually the MACE risk is 3 times higher, a little over 3 times higher. MI risk, 5.5 as the hazard ratio, and then ischemic stroke, 3. VTE kind of crosses that border, so or almost or is significant, but barely. And all-cause dementia was higher, but not all-cause mortality. And then what happens when we vaccinate? So let's first look at the early window, and you can see that there's a reduced risk of MACE, ischemic stroke, mortality, zoster infection, and severe disseminated zoster in the early window. You can see that that crosses the threshold for venous thromboembolism and only trends towards protection in all-cause dementia. In the late window, so looking just further out, you can see that you see these trends towards lower cardiovascular risk, but really only discrete protection in all-cause mortality. But then when you combine the time periods and look at early and late, again, we see that cardiovascular risk is outright lower. And the only thing that isn't is venous thromboembolism, severe disseminated zoster trends towards lower risk. So our conclusions here in matched people with HIV who were 50 or older and had one uncomplicated zoster episode, there was an increased risk of MACE outcomes, MI, ischemic stroke, and dementia. Those who were vaccinated had a lower risk of MACE, ischemic stroke, dementia, and all-cause mortality, and that was most apparent early, and that did persist through year 4. And so when I didn't show you those Kaplan-Meiers, you did see those curves nicely separate out into the later period. What I thought were interesting points, because I'm not a neuroimmunologist or a herpes virus expert in the most pathologic sense, I think one thing that I learned is that there's an arterial dominant clinical pattern to reactivation of zoster. So there's perineural travel to periarterial tissue in reactivation, which we think was why there's increased MACE, MI, and stroke outcomes. So anything that involves the arterial system and small vessel system, but not venous thromboembolism. And the other thing that they pointed out that I think is really important is that long after the rash, whether it's silent or if you have a rash, there's priming of endothelium and platelets. And so in that early period, That probably is why there is a higher risk of these outcomes altogether. And so their conclusions were that vaccine benefit was front-loaded but durable, and that to remember that HIV-associated inflammation and endothelial activation and damage may compound the risk that we're seeing with zoster. And so they pitched that neurocognitive and cardiovascular bundle should really focus on shingles vaccination along with things like statin and everything else that we talk about. Okay, and so our last section is screening, which is a big one, but I'll highlight two studies. So the first one was called Missed Opportunities, Gaps in Osteoporosis Screening Among Older Adults Living with HIV. And so as background, we know that HIV independently reduces bone mineral density in people with HIV, and that's a population in which fractures may occur earlier. Why? There's a lot of reasons that may be related to inflammation, immune deficiency and reconstitution, antiretroviral therapy, and I think often we're speaking specifically about TDF, and then the associated comorbidities like tobacco use, low BMI, vitamin D deficiency, and hypogonadism. As a result, the HIVMA, which I spelled wrong, but it is the HIVMA, primary care guidance suggests a DEXA scan in postmenopausal women and men who are at least 50 and or others based on individualized risk factors, such as those associated factors. So in this study that was done out of Wayne State in Detroit, they looked internally at their own adherence to guidelines for BMD screening in people with HIV in an outpatient clinic, identified the prevalence of osteoporosis and osteopenia among those screened, and determined those with diagnosis who are prescribed a TDF-containing regimen. And so again, just to get to the punchline a little more quickly in this one, this involved just 1 year of all patients greater than or equal to 50 years with one visit, which meant 856 individuals were eligible in their clinic. Screening rates were pretty low, right? So 26% of eligible female patients were screened and 18% of eligible male patients. The average age was a little bit higher in females, actually, so 63 years for men and 65 for women, and they all tended to have high CD4 counts. 49% had no prior TDF exposure that the authors could find, and there was a high association with low bone mineral density, but they also know that may have been a confounder, that we may have been screening more in people who they thought had low bone mineral density. But nonetheless, 64% of those screened had either osteopenia or osteoporosis. And so what they really are highlighting is that I think like many clinics, I think certainly in my practice, this holds true. We do need to increase screening for our bone mineral density. And I like that this was a very practical kind of clinic-focused study, and they really called for increased screening and ART optimization strategies. Okay, and then finally, another screening question. So this was called Who's Being Missed? Baseline Evaluation of Colorectal Cancer Screening in a Ryan White-funded HIV clinic. So again, as we know, cancer is now the leading cause of death in people with HIV. We also know that colorectal screening across the board in the American population is suboptimal, and it's unclear whether rates are lower or higher in people with HIV. So this was a retrospective review of the HIV clinic at the University of Nebraska of people with HIV who were older than 45, so the colorectal cancer screening age, evaluated in their clinic between July 2023 and 2024. The need for the screening was measured by the presence of a care gap, so as we have in our EPIC system, then manually verified, and colorectal screening via colonoscopy, FIT test, fecal occult blood test, and Cologuard orders and results were obtained and manually verified. So about 70% of the 761 patients were up to date, which was higher than the CDC kind of national average, but lower than the target 2030 goal for the nation, which is I think around 72%. But this is what I thought was interesting is that the associations with being not up to date are people who are a little bit younger in that screening category, people who spoke a language other than English or Spanish, people who were viremic, and people who did not have a PCP. So I think this will probably reflect a lot of people's anecdotal experience too. Also, 157 patients had some sort of cancer screening ordered. Those who were viremic and had multiple visits, but interestingly, 2 visits, not 3. We lost an association if you had more than 2 visits during the study year, were more likely to have invasive screening with a colonoscopy ordered rather than non-invasive. And that was 78% versus 55%. Completion rates I thought were interesting. Colonoscopy was a little less than 50%, Cologuard was 70%, and there was no reporting for the other testing. And I think really, again, to highlight our disparities here were in viral load, the language spoken, and having a PCP and then being retained in care. So I think what the authors concluded is instead of just applauding themselves for exceeding national screening rates for colorectal cancer screening at one center, disparities really persisted in their population of people with HIV. And so for me, it was a call to think about things like age, viremia, but also something that, again, I hadn't thought about explicitly, which was language discordance beyond English and Spanish. So thinking about Spanish as a different category. So takeaways, I know we kind of went all over the map here, but heavily treatment experienced people with HIV initiating lenacapavir in the real world largely maintained and or achieved viral suppression. As compared to non-zoster infected controls, people with HIV with zoster infection had significantly higher risk of cardiovascular and cognitive conditions, and those who had been vaccinated as compared to not had lower risk of poor cardiovascular and cognitive outcomes. And screening for comorbid conditions like bone mineral density loss and colorectal cancer in people with HIV has significant room for optimization.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.